Hi, my name is Linda Tilio. I've worked in the primary care clinic at the White River Junction VA for almost 10 years. My capstone project is the result of findings that I made during my research and evidence-based practice class last semester. I was researching a portion of a nurse-led triage protocol from a urology clinic in Michigan to determine if the recommendations that antibiotics be prescribed for symptomatic UTIs is supported by current evidence. The prescribing practice was supported in my literature review, but a different common theme was emerging. One article after another said that if an adult female is triaged and suspected to have an uncomplicated UTI, which we will dive into in a couple of minutes, there is no need for any diagnostic labs. A diagnosis can be made based on self-reported symptoms. This prompted me to take a second look at our outpatient UTI nursing policy, and I learned that it does not follow current evidence-based recommendations. At this point, I decided my capstone project would be to examine the role that labs play in diagnosing UTIs in our adult female patient population to see if we need to rewrite or maybe add a gender-specific nurse triage protocol. In this presentation, I will review the protocol, explain the differences between complicated and uncomplicated urinary tract infections, review the role that labs play in making a UTI diagnosis, and identify recommended treatment. Next, we will look at the results of women's health provider and primary care nurse surveys examining their thoughts on the need for diagnostic labs. Then we will look at the cost of 1 month's worth of primary care urine lab orders for female patients and see that changing order recommendations could result in financial savings. Opportunity costs will be touched on, and finally we'll review the next steps. The current outpatient protocol is written to provide guidance to registered nurses and licensed practical nurses on when to order a UA and CNS to assist in diagnosing UTIs. The protocol is applicable at the White River Junction VA and its associated CBOCs. A CBOC is a community-based outpatient clinic that is located in a remote area, providing better access to medical care for our patients when traveling to White River Junction is not practical due to distance. Our CBOCs are located in Burlington, Brattleboro, Keene, Littleton, Newport, and Rutland. Both men and women's health care is provided at all facilities. As of March 1, we collectively have a total of 21,096 patients, of which 1,491 are women. Per the protocol, nurses should order both labs when a patient presents either by phone or in clinic with any of the following symptoms: burning, frequency, new onset difficulty urinating, hematuria, flank pain, suprapubic pain, or foul-smelling urine. The problem with this protocol is that it is too broad and it does not allow for any triage based on gender or symptoms. The way it is written, all patients with symptoms suggestive of a UTI should have both labs ordered, and this practice is simply not supported by evidence. According to recommendations from the most recent update on UpToDate, the key in determining if labs need to be ordered to diagnose a symptomatic adult female lies in triaging the patient to determine if the UTI is complicated or uncomplicated. The symptoms of an uncomplicated urinary tract infection in a non-pregnant adult female include being afebrile, having dysuria, frequency, urgency, suprapubic pain, absence of vaginal discharge, and there's no suspicion that the infection extends above the bladder. There is no need to order diagnostic labs for this patient. Diagnosis can be made based on self-reported symptoms. For a complicated UTI, in addition to the symptoms listed on the previous slide, if any of the following symptoms are present: a fever over 99.9, other symptoms of systemic illness, flank pain, costovertebral angle tenderness, or suspicion that the UTI is above the bladder, or if a patient has relapses or recurrent infections, the infection should be considered complicated, and it is appropriate to order both a UA and a CNS for this patient. According to an evidence review published in JAMA in 2014, if 2 or more of the uncomplicated UTI symptoms are present in the absence of additional symptoms from the complicated list, you can predict with greater than 90% certainty that that patient has an uncomplicated urinary tract infection. The December 2017 up-to-date clinical guidelines suggest that the likelihood that the uncomplicated UTI is caused by the E. coli pathogen and the likelihood is between 75 and 95%. E. coli are frequently found in stool, and females are at high risk for this particular infection based on the female anatomy. The patient's diagnosis can be made based on self-reported symptoms via a nurse triage. With no labs needed and no need for a face-to-face encounter, patients can be treated safely and efficiently without ever leaving their home except to go to a local or to the VA pharmacy to pick up their medications. The exact medication that the prescriber orders to treat the infection can be guided by the local antibiogram, which determines the best medication based on microbial resistance patterns. Women should expect a positive response within 2 to 3 days, and if there's no symptom relief, she needs a culture and sensitivity to identify the true pathogen so that medications can be adjusted accordingly. Providers should not treat asymptomatic UTIs. Sometimes discovering the presence of bacteria in urine are incidental findings as a result of lab orders in an emergency room, for example, as part of another workup. This patient may be colonized, and treatment with antibiotic leads to increasing microbial resistance and potential difficulty treating symptomatic UTIs in the future. So what do women's health providers think about the importance that a UA and a CNS play in diagnosing a UTI? A survey was sent via SurveyMonkey to 20 women's health providers at the White River Junction VA and the C-Box. These providers were asked the following. An adult female calls the clinic with symptoms suggestive of an uncomplicated UTI. She is not able to come to clinic for evaluation or to leave a urine sample. Will you order her the appropriate antibiotic anyway? 9 of the 20 surveys were returned. In this pie chart, you can see that 78% of providers would be willing to prescribe antibiotics to this patient. Interestingly, though, the same survey participants were asked if this patient was able to provide a urine sample at a clinic visit, would they order both a UA and a CNS? And 67% of the time, providers would rather have the labs versus prescribing based only on symptoms. A 2017 survey published in JAMA and a systematic review and meta-analysis published in 2018 in the BMJ reported that U.S. physicians feel that overall about 25% of lab orders are unnecessary, and the vast majority order these labs due to fear of litigation. So providers are frequently practicing defensive medicine. Another common reason is not being able to keep up to date on the rapidly changing evidence-based recommendations. A survey was sent to 29 nurses in primary care at the White River VA and the C-Box, and 14 surveys were returned. Only 2 of the 29 nurses are assigned specifically to the women's clinic, and I don't know if they completed the survey or not. So the question is, an adult female calls the clinic with symptoms suggestive of an uncomplicated urinary tract infection and wants to see a provider. What percentage of the time do you think you should order both a UA and a CNS before the provider sees the patient? The survey indicated that 86% of the nurses believe they should order both labs to assist in the diagnostic process. This may be because they're following the protocol. They may truly believe this practice is evidence-based or a combination of both. Our lab services are contracted with equipment manufacturers using a basic cost per reportable for each lab test performed. It is called a cost per test contract, and it includes the equipment itself, reagents, calibrators, the control material, all disposables, training, and a standard service agreement. It's a win-win situation because there's no heavy outlay for equipment purchases, no heavy outlay of money for equipment purchases, and we are always able to trade up to the newest equipment every 5 years since we have no ownership and we're only leasing the equipment. So when a UA is ordered, it is run through an automated dipstick test. If there's anything of interest, including leukocytes, nitrites, blood, or protein, the urine is reflexed and put under the microscope for further analysis. If none of those show up in the urine, that's the end of the test, and it stops right there. But if the CNS is ordered, regardless of the UA results, the sample is placed in a growth medium in a Petri dish, incubated and allowed to grow, and then to ID the bacteria to determine antibiotic sensitivity. So right now these are two separate independent orders, and they are frequently ordered together. I worked with the lab manager to obtain costs per order in an attempt to put a dollar figure on potentially unnecessary labs. During the month of October 2017, 22 urinalyses were ordered for females in these clinics. 14 had added microscopy, and 18 had simultaneous culture and sensitivity orders. The cost of a UA per contract with the addition of VA lab personnel is $4.33 per occurrence. The reflex microscope cost was difficult to analyze by the lab, as there's many variables that can affect the cost. For example, the necessary skill level of the lab tech, the time involved, and any additional materials that might be needed. So a rough estimate was $7.10 per occurrence. The cost of the culture and sensitivity per contract, including the lab personnel, is estimated at $30 per order. The results of a systematic review and meta-analysis published in February of 2018 in the BMJ found that between 55 and 77% of UA and CNSs ordered in the primary care setting in the United States are clinically not indicated, and the overuse of tests when potential for harm outweighs the benefits can subject the patient to real harm. Several of the research articles that I reviewed reported results from internal cost reduction strategies, and all were successful in reducing expenses when internal stops were placed in the system to prevent the over-ordering of unnecessary labs. For example, a 2011 QI initiative in the Syracuse VA showed a reduction in lab costs simply by implementing utilization software. A popular financial model for healthcare facilities in the United States is fee-for-service. Medical services are bundled and paid for separately, or unbundled and paid for separately. This model provides incentives for ordering tests, treatments, and procedures as they are income producing. This model provides incentives for ordering tests, treatments, and procedures as income is based on the services that are provided to the patient. In this model, labs equal income. But the VA is funded through the capitation system. Capitation financing is a prospective payment system that pays a fixed amount per enrollee for a defined set of time for a defined set of health services, regardless of the services that are used. In a government-funded hospital, labs are expenses, and it is important that they not be ordered frivolously when unwarranted. Not only do we owe it to our patients to be current on evidence-based recommendations, but we need to be good stewards of our taxpayer dollars. There may be some financial reimbursement for women if our women have outside insurance. I was not able to obtain any information on that. Next, we talk about opportunity cost, which is the value of something that must be forfeited in order to achieve something else. Because every resource can be used in an alternate way, every decision has an associated opportunity cost. By ordering unnecessary labs, there are associated opportunity costs as follows. The lab, equipment, and staff are spending time collecting and processing specimens that don't need to be processed. Resources could be otherwise utilized for clinically indicated labs. Providers and nurses don't need to be spending time ordering and following up on unnecessary labs. There are plenty of other demands on our time. Scheduling appointments for patients that don't need to be seen reduces our access for patients that truly do need a face-to-face eval. And maybe most importantly, the patients save time. They don't have to miss work, etc., because they don't have to come to clinic for any unnecessary labs and potential face-to-face visits. So my next step is to meet with the Evidence-Based Practice Committee to present my findings. Then I will need to develop a nurse triage protocol to separate uncomplicated from complicated UTIs for our adult female patient population. I would then like to educate the nurses and the providers about current lab recommendations for diagnosing UTIs. If a change in the protocol and nurse provider education is not effective in reducing the number of labs ordered, we could consider adjusting the lab ordering process itself, it might make sense to have a reflexed UA, CNS, and CNS order. In other words, if the UA is negative, don't do the CNS unless there are extenuating circumstances. To measure the result of changing the protocol, further lab data should be obtained looking at additional months both prior and after the protocol change, so we can compare and see if the numbers of urinalysis and culture and sensitivity orders has declined.